My name's Izzy. I'm a brain tumour ambassador.
Yeah. Hi, I'm Molly. I'm a young ambassador for the Brain Tumour charity, and we're here with Professor Susan Shaw today to ask us some questions.
My first question is, what is happening to treatment now? Is it different across the UK and for different groups of people?
Yes, thank you for that question. It's quite a big question, really. And as you say, it probably isn't exactly the same everywhere in the UK because of all of this change is about what's happening with the coronavirus outbreak. And obviously that's affecting different parts of the UK slightly differently at any one time. But I think it's probably fair to say that throughout the country, everybody's having to think about whether treatments need to change. That's partly because of a concern about patient safety, particularly for patients who need chemotherapy, the sort of drugs that affect your immune system. We're all having to think very carefully about what is the right situation in which to recommend that sort of treatment that would make patients potentially more prone to picking up infection and getting serious problems with an infection like coronavirus. So we're being forced to think about changing treatment from that perspective. And I think it's true across a lot of the country as well that we're being forced to think of change because of the resource limitations. So mainly personnel, so doctors and nurses that are being asked to contribute to looking after patients with coronavirus, which means that they're not around so much to help us look after our cancer patients. So that is making us think differently as well. So I think the straight answer is treatments are changing in different ways.
So we were also wondering, what assessments are you making as a team? Is it on like a case-by-case basis? And how are you prioritising or making different decisions for different groups?
Again, that's a very good and a very big question. There are two general answers. So we always assess each patient as an individual. So we always make case-by-case decisions at the end of the day because we have to explain to patients why we've made those decisions. And obviously everybody's a little bit different and the risks and benefits will vary from person to person. So we always have to think about that. There are some general guidelines that have been issued by NICE, so by the government, about the considerations we should be thinking about, especially for chemotherapy treatment. And some other organisations around the UK have put out some guidance as well. And that just gives us sort of broad frameworks that really help us think about which patient groups we should be focusing on, remind us which patient groups we're going to have to make the more difficult decisions on. And they're trying to give us some general help really in terms of making those decisions because they're often not easy, as you can imagine.
How do you anticipate the situation will change in the coming weeks and what are you prepared for?
So that's a difficult question because of course nobody really knows what these next few weeks are going to bring. We're all expecting the peak of these coronavirus infections sometime in the next few weeks, but I don't think any of us really know exactly how much that will impact the service. We're expecting that it will have a significant impact in the ways that I've just talked about. It will impact us in terms of the personnel, the doctors and nurses and pharmacists and radiographers and all the people that we need to run the service that we do day to day. We're expecting it to impact on that, and we're expecting to have to work around having a much smaller workforce. Exactly how big that impact is, I think we don't know, but everybody, all trusts around the country are preparing, are making preparations to think about how to work efficiently so that we can still deliver a service.
What advice would you give to someone whose treatment has been postponed or is currently cancelled?
So I think for a patient whose treatment has been postponed or cancelled, I would assume that they have already had a discussion with their treating team about why. We really wouldn't just cancel treatment or postpone treatment without having a discussion with the patient. And so that discussion should have included some idea about why we think it's reasonable to delay or postpone or cancel treatment. So we would hope that the patients understood that's a consideration about the risk to them versus the benefit to them of having treatment right now. And it's not necessarily about stopping treatment altogether. Often it is, as you say, it's about postponing it and not putting patients at risk over these critical next few weeks when the risk of infection is going to be high, and the resource in the NHS is going to be very, very squeezed.
If the situation changes, how often are you reviewing it, and how are you notifying people of any changes?
Yeah, so that's a good question as well, because things are obviously changing very, very quickly, day to day, really. For most clinicians, we run timetables that are sort of the same every week. So we have regular clinics on certain days every week. So for us, it makes sense really to review things weekly, and decide what we can or can't deliver in a week, and what we should be doing about patients who we would otherwise be seeing that week. So we're trying to work it in that way, so that towards the end of this week, for example, we'll be looking through all the patients who we're expecting to see next week and making decisions about whether we should still see them in the clinic as planned, whether we will speak to them on the telephone instead, whether we think we need to talk to them about changing their treatment at all. So we're doing it more or less week by week. But obviously things sometimes change more quickly, particularly for individual patients, and then we would respond, whenever things change. For the patient, we would try and give them advice at the time.
Are a lot of stuff being done like over the phone, and like is that how meetings are being run now?
Yes, there's been a remarkably quick change actually. So everybody over the last many years now has used technology like we're using right now for meetings. But historically we've really relied almost entirely on face-to-face, especially for patients. It's just the traditional way that consultations are done, right? But yes, suddenly we've been forced to the situation where we really don't want to bring patients up to hospital. We don't want to put them at risk of being in this sort of environment. We don't want to force them to travel unnecessarily. So we're doing a lot of consultations by phone. So it's been a very steep learning curve, I think, for everybody. But actually, it's surprisingly effective. You can do a lot of a normal consultation by telephone. So we're learning, and I think the patients are learning, and I think it will likely change the way that we do our consultations long term, because I think there are some patient groups who we probably rarely really do need to see in the clinic.
If there's any recourse, if people disagree with the decision about the treatment in their case?
Yes, so that's a good question as well. So I mean, ideally we want to make a joint decision with all of our patients. We want them to understand our point of view, and we need to understand their point of view, because some of it's about understanding what they think of as risk and what their expectations are. So we want to avoid the situation where we feel that we're forcing a decision on a patient. But obviously sometimes there might be a disagreement. Some patients might feel strongly that they would like to go ahead with treatment even though we feel it would be risky for them. There's always room for more discussion. And there's always room for other opinions. So I think one of the first recommendations we'd make in that sort of situation is for the patient to have a discussion with a different clinician, just to see whether that helps them understand each other's position better. At the end of the day, we have guidelines, but we don't have fixed rules about who we should or shouldn't be treating. It really has to be an agreement between the patient and the doctor, ideally.
Some people have been told that it's their choice whether to go ahead with chemotherapy as planned. How do they make this decision? And if it was a patient that you were dealing with, what advice would you give them?
Well, I think that it's very, very difficult, because again, it's individualized. I think we have to try and explain to patients what we understand the risk is, and we don't really know the risks very in much detail. We know that all patients who've got a cancer diagnosis are more at risk from this sort of disease, from a virus sort of infection. We know that patients who are on chemotherapy are more at risk of having a low immune system, which makes them, again, in a highly vulnerable category in terms of infection. But, we can't say for each individual patient exactly what the risk is of picking up the infection, and we often can't really say what the exact benefits are of continuing chemotherapy or not. We can only give general advice. We have reasonably good idea for a lot of our patients who are the ones where chemotherapy is a really critical part of their treatment and we would not want to delay it. And those for whom, for example, the ones with slowly growing, lower grade tumours where actually, yes, they're going to need treatment, but they may not need it this month or next month, or, you know, where delay is not such an issue. So we have some understanding, but we're not very good really at predicting for individuals what this risk ratio looks like. And I think that does make it difficult for everybody. And what we are doing more and more is, instead of asking patients to come up to the hospital to pick up treatment, especially if it's just tablet medication, we're sending it straight to their home. So they don't actually have to come here to pick it up. So they're getting it delivered at home. So that's not quite the same as having the GP doing the whole thing, but it means that more of the service is direct to the patient without them having to come up and hang around in hospital. So we're trying to do that as much as we can with chemotherapy and with routine medication as well.
If people are having treatment, can they be tested for coronavirus?
Yeah, well, we need to ask one Mr. B. Johnson that, don't we, really? At the moment, the testing situation is evolving very quickly. But for patients out in the community without symptoms, there is no access to testing as far as I know at the moment. Patients who are unwell, who come into hospital with symptoms that might be coronavirus, do get tested. But they're the only ones that are getting tested at the moment.
People who've only just gone into remission, so surely they do need to have some more support. So is that something we can do over the phone, or do they need to be seen face to face with their doctors and consultants?
Yeah, so again, it depends very much on the situation. I think there definitely are still some circumstances where it's very difficult to do a consultation over the telephone. And that may be, as you say, for people who've only recently come through treatment and are just getting over it. And we really need to give them day-to-day advice about how to manage their symptoms. It's also the case for patients who may have developed new symptoms and we don't really know why. It's difficult to get to the bottom of that often over the phone if you can't actually see the patient, talk to them in detail and examine them to see really what the symptoms are, particularly for brain tumour patients where you're looking for neurological symptoms. You really can't establish those over the phone very easily. So I think there are some circumstances where we do still need to do face-to-face consultations, but actually it's turning out to be quite a low proportion. We're probably putting, well, definitely at least 75% of our clinic appointments at the moment are going to telephone. So that's quite a big percentage really that we're not doing face-to-face. Yeah. But things are changing. So what I've said now this week may be different this time next week, but you know, we don't know. We don't know what the future holds, and that's part of the scariness of the whole situation, really. And I think one of the things that makes it pretty difficult to deal with.